This video is part of a series on evidence-based planning using the bottleneck analysis approach. In this video, we define the concept of health equity and the role of health equity analysis as part of the planning process. When doing evidence-based planning, we start with a detailed situation analysis. We look at our data and ask, what is the current state of health? What are our biggest concerns? How is our performance across key program areas? And are there areas or groups that perform worse than the general population need priority attention? This last question is the starting point for health equity analysis. It looks at how health varies between population groups and helps focus our attention on those groups with the lowest access to health services and the worst health outcomes. The World Health Organization defines health equity as the absence of avoidable, unfair, or fixable differences among groups of people. Let's explore this concept with a simple example demonstrating the differences between equality and equity in terms of service delivery. In this example, the fruit represent good health. The people represent our target population, and the boxes represent our available evidence-based interventions. The target population wants good health, and they need our services to improve and maintain their health. But there are differences in health and differences in opportunity for health between the population groups. In this example, height represents these differences. Some groups have a bigger gap to good health than others. When delivering services, equality sounds fair, but equity is fair. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. Planning for health equity means recognizing that some groups face bigger obstacles than others. These groups may struggle to access services or may have worse health outcomes than the general population. Planning for health equity means matching the right amount of help to the need for help. Those groups with lower access or worse outcomes may need extra resources or different interventions to improve their access or to achieve similar health outcomes as compared to the general population. Planning for equity also means understanding and planning to reduce barriers that contribute to these differences in health or differences in opportunity for health. When planning for health equity, we ask, who are the most underserved? Where are they? How big is the gap in access? How big is the gap in health outcomes? What are the drivers of inequity? To help answer these questions, we analyze our data by population groupings, or what we call equity stratifiers. Depending on our context, we may analyze by age, sex, ethnic group, wealth quintile, residence, education status, occupation, or disability status. To work towards improved health equity, we analyze our data to find the underserved and understand their obstacles to good health. We develop plans that match the amount of help to the need for help. And we prioritize distribution of resources to give extra resources to those most in need. A good health equity analysis unmasks avoidable, unfair, fixable differences among groups of people. It shapes focused action plans and a more fair allocation of resources. Since health inequities tend to cluster, fixing them can result in big performance improvements. We often experience a knock-on benefit and see improved coverage and noticeable gains in health outcomes across multiple areas. Addressing health equity in the planning process will make the health system more just and contribute significant gains in improving universal health coverage, which requires that all people have access to quality, affordable health services.